Right, so we finished our chapter 8 and onwards to chapter 9. Here we are, and this is all about the study of arthrology. So arthro is the prefix for joints. So arthropods, as an example, literally means jointed legs, right? And that is a large uh, arthropods, a large group of critters. Insects belong to that which, right? Arthropods, that includes insects, arachnids, spiders, scorpions, ticks, mites, crustaceans, these marine creatures like crabs, lobsters, crawfish, right? Um, Millipedes and centipedes. What all of these creatures have in common is the fact that their bodies are jointed, right? And therefore the prefix arthro, arthritis, that is an inflammation and a pain of the joints, and something that we will continue to address in our future lectures as well. So the doctors who deal with problems of the joints are called, well, you would say arthrologists, but a more commonly used term is rheumatologists. So rheumatology, again, is the study of joints and everything associated with them. Okay, so here, let's go ahead and take a look at some of the anatomical or structural classes of joints, right? We look at three of them. Fibrous joint, it's very tough, it's not movable. Immovable or barely any movement there. Cartilaginous joint, again, not very mobile, but quite resilient. Synovial joint, these are the most movable joints. And when you think of joints, you think of like your fingers, neck, wrist, ankle, whatever, elbow, all of those belong to the synovial joint type. They're called synovial joints because the joint cavity is filled up with the serous fluid called the synovium, okay? And I'll give you a common formula. If you can crack your joint, if you can make that popping sound, it's a synovial joint. That popping sound, by the way, is not the sound of your bones rubbing together or anything, right? That would be excruciating pain and cause arthritis in no time whatsoever. But basically, cracking your knuckles is more akin to popping open a bottle of champagne, right? So when you take off the cork with a loud popping sound, knuckles, what did I do wrong here? Knuckles. Okay, so there. So what happens is when you like, let me try doing this here. You heard that? So yes, I popped my finger. So by rapidly changing the position of two bones in relation to each other, the synovial joint is displaced. The synovial fluid is displaced in a hurry, and that causes some of the dissolved gases in them, like carbon dioxide bubbles, to pop open, right? So it's just like popping a cork off of a bottle of soda or champagne or whatever. Same thing here. And no, cracking your knuckles doesn't cause arthritis. So you can safely crack them. Okay, I'm not recommending it, but there's nothing against it either. So here is the physiological or functional classes of your joints: synarthroses, amphiarthroses, and diarthroses. Syn means joined. So these are immobile joints because they're joined together, right? Can be either fibrous or cartilaginous in anatomical terms. Amphi means both, half and half. These are slightly mobile, again, could be either fibrous or cartilaginous. Diarthroses are freely movable. So your synovial joints, as an example, the ones that can move freely are examples of diarthroses, okay? So range of motion at joints, or ROM. And this is something that you would often assess as your work as a nurse or a doctor, a range of motion. People come with problems of arthritis or even trauma or injuries. You'll see what is the range of motion of different joints, okay? And so that's what we are looking at here. So the general rule is the more stable a joint is, the less mobile it would be. The more movable a joint is, the more mobile, the less stable it would be. Okay, for example, the shoulder joint, very movable in all directions, but not very stable. You can easily dislocate your shoulder, but your hip joint is almost impossible to dislocate, but it's not very mobile, right? So that's the relationship between mobility and stability. It's like an inverse relationship. Are all fibrous joints also synarthroses? Yes, they are also synarthroses. They're kind of joined together. Okay, so fibrous joints, no joint cavity, no synovial fluid, not much movement there. They're tightly packed or joined together. Three common examples are gomphoses, sutures, and syndesmoses. Let's take a look at the first subtype of fibrous joints, gomphoses. They're found in the gums. So that makes it easy because gum kind of sounds similar, right? So here you're looking at the gum and the tooth. So this joint between the tooth and the gum right here is an example of gomphoses. And the structure that holds your tooth in place firmly is something called the periodontal membranes, and you can see them here, the periodontal membrane. People with advanced gum disease, something called periodontitis, in them, because of chronic infection, the periodontal membranes become lax or loose, and so they are at risk for losing their teeth. Periodontitis or chronic gum disease is the #1 cause of tooth loss throughout the world, okay? More common in diabetics again. Okay, sutures. Perfect example would be your skull bones. We looked at our coronal suture, the sagittal suture, lambdoid suture, all of them, right? So these are, again, fibrous joints, very tough, very resilient, and not very mobile, as you can see. Okay, syndesmoses, whenever you have an interosseous membrane between the two bones, what comes to mind? Radius and ulna in your forearm, and then tibia and fibula in your lower leg. Those are examples of syndesmoses or amphiarthroses. So the only actions you perform there are pronation, supination, pronation. Same with your leg down there, supination and pronation. Where are gomphoses located? In the gums. And what type of movement do they allow? None. Your tooth has to stay fast within there. What is the composition of a suture? It's a fibrous joint. Where in the body is it found? In between the skull bones. What type of movement is allowed in a syndesmosis? Think radius and ulna, pronation and supination. Okay, cartilaginous joints, again, are quite immobile. They're strong. They do not have a joint cavity. And there are two examples of cartilaginous joints, synchondroses or symphyses. Again, chondro, that means cartilage, the prefix, we talked about that before. So let's take a look at synchondroses, which literally means syn means joined together. Cartilage, which is joined together. Where are you going to look for those? At the ends of your long bones, like in the epiphyseal plate, right here. The epiphyseal plate, synchondroses, or your costal cartilage. Costal means what? Ribs. So your costal cartilage right here is another example of synchondroses. So not much movement either at either of those places, right? Symphyses, two examples. Pubic symphysis, right here. We talked about that joint before. Here's the subpubic angle. So who is that? A male or a female? That's a male, correct. Subpubic angle is less than 90 degrees, an acute angle. And the other place where you have a symphysis is in the intervertebral discs, in between the vertebrae, as you can see here. Okay, so here we are looking at a clinical picture called costochondritis. You can tell me what that is. Just look at the term costo, ribs, chondritis, inflammation of the cartilage. So inflammation of your rib cartilage felt here in the front of the ribs. This is all cartilage, right? Either because of a blow to the chest or wearing like a tight corset or a tight bra for females or something like that. Sometimes because of like sleeping in an awkward posture, or all kinds of things can cause it, okay? Infections. But the big thing here is you have to differentiate it from myocardial infarction, a heart attack. That is critical. How would you do that? Somebody presents to you with acute chest pain. How are you going to make sure it's not like something like rib pain, costochondritis versus a myocardial infarction? You'll do an EKG. What will you see on an EKG? You'll see a couple of things. You'll see something called a T wave inversion, right? So let me just quickly write it down here. EKG, you'll see a T wave inversion and ST segment elevation, okay? Something you won't necessarily see with costochondritis. And then you can also send your cardiac enzymes for a study to see if they're elevated or not. But that is an important distinction you have to make here. If it's costochondritis, just ibuprofen, like Tylenol, Motrin, those things would should take care of the situation. What is the composition of a synchondrosis? It's a cartilaginous joint. Where in the body is it found? It's found in your epiphyseal plates at the end of long bones and in the costal cartilage. Symphysis is what? Symphysis is a cartilaginous joint again. Why is it in this category? Because it contains fibrocartilage. Synovial joints, the most common type, they're diarthroses, meaning they're freely mobile. They're able to move in all different directions, okay? And here's an example of a synovial joint, as you can see, okay? The two bones coming in, articulating with each other. Here's some articular cartilage to prevent the bones from rubbing against each other. It's like a protective capping. As you get older, this might get chipped away, and that's when you develop things like osteoarthritis or rheumatoid arthritis or things like that. This is an adult. How do I know? There is an epiphyseal line, not a plate, just a faint line. So the bone has completely ossified. I can see bone marrow, yellow bone marrow here as well. This is the synovial cavity filled up with synovial fluid in purple. That's a tough outer fibrous capsule that surrounds and protects the joint. So outer fibrous layer that we saw in the picture, and the inner synovial membrane that secretes the synovial fluid. All right. So what are tendons then? Tendons versus ligaments. Ligaments are tough connective tissue types that join bone to bone. Two bones are joined together by ligaments. Tendons are tough connective tissue that join muscles to bones, skeletal muscles to bones, okay? Bursa or bursae, these are these fluid-filled sacs, like this one here in your, where is it? In your knee joint, right? How I knew this was a knee joint, I looked at the muscles, gastrocnemius, those are your calf muscles, okay? So these bursa, they also prevent friction in between the joints. They're filled with the serous fluid, right? Synovial fluid, and they're called bursa. Some other structures that protect friction, protect you from friction of your bones are things like tendon sheaths. These are your tendon sheaths, okay? So they're filled up with synovial fluid again, and the tendons of your, connecting your muscles to your bones, they run through these water-filled sheaths so you don't have friction, okay? And also fat pads, they also prevent friction. So we're nicely equipped to prevent friction, unless you have like carpal tunnel syndrome or something that we'll talk about later on as well. Okay, different types of joints. Uniaxial, bone moves in just one plane. Biaxial, bone moves in two planes. Multiaxial, bone moves freely. The joint moves in all directions. Okay. So now, how do you classify your synovial joints? Well, this is one way of doing it, from the least mobile to the most mobile, okay? The least movable to the most ones. Plane joints are the least mobile. Then hinge joints, pivot joints, condylar, saddle. The most movable or mobile of all are ball and socket joints, like your shoulder joint and your hip joint. Most mobile, ball and socket, like a ball-like head of a bone fitting into a socket. For your shoulder joint, that would be the head of the humerus fitting in the glenoid cavity of the scapula. For your leg joint, it would be the head of the femur fitting into the acetabulum of your os coxa, or the hip bone. Okay, so plane joints, they are just flat surfaces, okay, least mobile. They're synovial though, limited side-to-side movement in a single plane. That would be the joint between your metacarpals, these bones of the wrist, plane joint. Hinge joint, it's like your elbow or your wrist, okay? So it's like the hinges of a door, literally flexion and extension. Those are the movements that you perform here. Pivot joint would be like your, like the head of the radius and the ulna, how they're held together by the annular ligament. They can still rotate when you supinate or prone your arm, right? Supination, pronation. So the heads of the two bones can like kind of pivot around each other. Condylar joint, that is something you see in your, for example, your jaw. When you open your jaw, your mandible, that's a condylar joint, right? Saddle joint, like your thumb. It's like a saddle, right? You can rotate in different directions. And ball and socket joint, again, your shoulder and your hip joints. What are the basic characteristics of all types of synovial joints? They're very mobile and they contain synovial fluid. There are also types of diarthroses. What is the purpose of synovial fluid? To prevent friction and to allow you to crack your knuckles. What types of movements do each of the 6 kinds of joints allow? Go back and check. All right, so a gliding motion is where the bones simply slide back and forth or side to side, okay? For example, again, in between your carpal bones or your ankle bones in the tarsal bones. So what are the different motions that you can perform between two bones? Flexion and extension, hyperextension, and all of these. So what is flexion first? Flexion is defined as when two surfaces of your bones come closer to each other. When the angle between two bones is reduced like this, flexion. Or in your leg, when you bend your knee backwards, the angle between two bones decreases. That's flexion. Extension is the exact opposite. When the angle between two bones increases, this is extension of the arm, right? This is flexion of the fingers. They come close to my palm. This is extension of the fingers. They move away from the palm. So there you go. Hyperextension is when you do this, the fingers extend, or with your neck, when you look up, this is hyper extension of the neck, right? This is flexion of the neck. This is extension of the neck. This is hyperextension of the neck, like a whiplash injury is what that would look like. Lateral flexion, when you twist your torso to the side, that's lateral flexion. So here, look at the guy, flexion of the neck, extension, hyperextension. Again, flexion of the arm, extension of the hand, hyperextension, extension, flexion, flexion and extension in the leg, and lateral flexion. You can see all of them. Okay, some more movements: abduction and adduction. Abduction, as you see in the picture, is moving a body part away from the midline. So this is abduction of the shoulder. Same with the leg. Abduction of the leg, moving it away from the body, bringing it back towards the midline of the body. Adduction of the arm here, adduction, leg, adduction. For your hand, moving it away from the midline in the anatomical position. Abduction, moving it closer to the midline, adduction. Same with the fingers. When you spread your fingers apart, this is abduction. When you bring them together, this is adduction of the fingers, okay? Circumduction, when you move your arm or your wrist in a circle, or your foot for that matter. That's called circumduction, moving that body part in a circular pattern. Okay, rotation, lateral rotation, when you move your hand laterally away from the midline. Medial rotation, when you move the arm back. So again, here, lateral rotation, medial rotation. For your face, lateral rotation away from the midline, medial rotation back to the midline. Same with your foot, lateral rotation away, medial rotation towards the midline. Pronation and supination. Depression and elevation, depression of the shoulders, like when you slouch your shoulders, and when you elevate them, that's elevation, right? Like shrugging your shoulders up like this. Dorsiflexion is when you move your foot upwards, as in the picture. Plantar flexion is when you move your foot downwards. When you flex your foot towards the plantar surface. Plantar surface is the sole of the foot because it plants you on the ground. So plantar flexion. Eversion, moving the foot outwards, and inversion, moving the foot inwards, as you see. And this is how most people get a really bad sprain, right? Inversion injuries are way more common than eversion injuries. Why? Because we have a very strong cartilage ligament, rather, called the deltoid ligament, which protects our medial side of the foot. So it protects us from tearing. But there's a very flimsy lateral ligament here, which is prone to wear and tear. It can tear easily, and a sprain is a tear in your ligament, and that happens most easily here in an inversion position. Protraction, retraction. So moving your jaw, your mandible outwards is protraction, like an underbite. And an overbite, like retraction, is when you draw your jaw back in. Opposition, as you can see in the picture, right? And reposition, opposition, reposition. So what joints typically use gliding motion? Your carpal and tarsal joints. How do flexion and extension differ? Flexion is the angle decreases between two bones. Extension, the angle increases. What movements are involved in circumduction? Circular. What is pronation? Prone, downwards. It may be performed in your hands. What is the difference between inversion, when the foot is inverted, versus everted? Which joints allow these movements? Your ankle joint, of course. All right, so here we're looking at some basic physics 101, like levers, okay? And I was never fond of physics in particular, so we'll just skim through some of this here, okay? So we have these three types of levers that we are looking at. So let's start with the first example, okay. A first-class lever, so a real-world application would be a seesaw, as you see here, right? So you have the effort or the weight on one end, then you have the resistance or the opposing weight on the other end. There's a balancing point called the fulcrum here. So that is a real-life application of a first-class lever. Another example is scissors. So you have the effort arm, which is where you basically try to cut at. The resistance is whatever object you're trying to cut. The fulcrum is where the two two tongs, the two arms of the scissors come together. In humans, what is an example of a first-class lever is when you hyperextend your neck, when you look upwards. So the resistance here, of course, is the gravity pulling your chin down. The effort is the contraction of your neck muscles, and the fulcrum is the base of your neck, the base of your skull, rather, right over there, okay? So that would be an example of how a first-class lever kind of mechanism helps you hyperextend your neck. An example of your second-class lever is what you see here in terms of a wheelbarrow, okay? And in wheelbarrows, of course, you have the effort, the weight that you lift up here, the resistance is the weight within, and the fulcrum is in the front. So what would be an application of a second-class lever in human terms? When you tiptoe. So when you tiptoe, the effort is the contraction of your calf and your leg muscles upwards against the gravity, and gravity is your own weight. The heavier the person, the greater the resistance would be. That's why people who are heavy and obese also get flat-footed, and their arches become flat, right? And then the fulcrum is the balls of the feet on which what you're using to tiptoe, basically. Then third class lever, and an example would be tweezers or forceps. So here is the effort arm that you press. The resistance is whatever object you're trying to hold with the tweezers. Fulcrum is all the way here. And a perfect example of a third class lever in human terms is when you flex your biceps, okay? So in that case, the resistance is the object or the dumbbell, whatever you're trying to lift. The fulcrum is your elbow joint. The effort is the force of your biceps, as you can see here in this picture. So difference between effort and the resistance arm. Effort arm is where you apply the force. Resistance arm is the weight you're trying to lift. So what's the difference between first, second class, and third class levers? Go back and refer to those slides that we just saw. All right, temporomandibular joint, or TMJ. As you can see here, what is this? This is a kind of synovial joint, because you can literally crack your jaw as well, your mandible, okay? And this is what that joint looks like right there, right? Your mandible sitting in snugly into this temporomandibular joint here. And there's many ligaments which reinforce the joint. The temporomandibular ligament from the temple down to the mandible, right? Also the sphenomandibular ligament from your sphenoid bone to the mandible again. So these are enforcing it. You can also see the styloid process sticking out from there too. Here is your synovial fluid within the temporomandibular joint, as you can see, okay? So TMJ disorders, if you open your mouth too wide or like yawning, sometimes you can dislocate your mandible here, and that's painful. You'll feel the searing pain going all the way up to your head, down to the neck, and then all you have to do is to push the head of the mandible back into the socket, and it makes like a clicking sound, and the jaw closes reflexively, okay? So these are your shoulder joints. So that includes your clavicle, which is your collarbone, right? Your clavicle has a sternal end, which is a synovial joint with the sternum, and then also an acromioclavicular joint, which would be on the lateral side over here. So then here you're looking at your shoulder joint again. So the head of the humerus fitting in nicely and snugly into the glenoid cavity of the scapula. As you can see, this is a ball and socket joint. There's many ligaments, coracohumeral ligaments, the coracoclavicular ligament, right? What else? Glenohumeral ligament. And the names tell you where they're coming from. Glenohumeral, it connects the glenoid cavity with the humerus. Coracoacromial, it joins the coracoid and the acromion together. So the names, the prefixes tell you where those ligaments are located at, okay? And you can also see the tendon and the bursa of the biceps muscle over here in this picture. All right. Shoulder joint dislocation. So most of the dislocations in the shoulder joint are inferior, downwards. So if you raise someone's arm, abduct it, and give a nasty blow, strong blow downwards, it's easy to displace it inferiorly, because the inferior part is where there's not much protection. There's not many ligaments holding the joint in place, okay? So that's where shoulder joint dislocations are most common. Again, you have to pop it back into its socket. The elbow joint, it's an example of a hinge joint, right? Flexion and extension, which are possible here. Here's your elbow joint in between the distal end of the humerus and the radius and the ulna. They're held together by many different ligaments as well, like the annular ligament, which holds the heads of the radius and the ulna together, right? Then you also have the radial collateral ligament on the lateral side and the ulnar collateral ligament on the medial side. So all of them reinforce your elbow joint as well, which in itself is a synovial um, hinge joint. It's filled up with synovial fluid in purple. You can see it here. Flexion and extension is what is possible at your elbow joint as well. These are all the ligaments that stabilize the elbow joint that we just talked about. Okay, subluxation. So this is something you will see in young kids, young children, especially if you attempt to like pull them up or lift them off the ground using their arm or something. So when that happens, the head of the radius sometimes snaps out of the annular ligament that is holding the ulna and the radial heads together. The radius kind of pops out of the ligament. Okay, and when you see that, and the immediate result is the child is unable to extend their arm. They're going to hold it like this, as if it's in a sling, in an invisible sling. So, and there's some pain, or obviously the child would be crying. But if you see this in a child who presents to the ER, again, with like maybe bruises or other signs on the body, high index of suspicion for child abuse, okay? Someone was rough with the child, or pulled their arm or whatever. So subluxation injuries are common. Fortunately, the treatment is, again, if the doctor knows what they're doing, they can simply pop the head of the radius back into the annular ligament altogether. So by maneuvering and manipulating the bones, you can do that. All right, here's the hip joint. So the head of the femur fitting into the acetabulum, which is this shallow cavity on your os coxa, on the hip joint. So you can see that. And again, number of ligaments enforcing this joint: the iliofemoral ligament from the ilium to the femur, the pubofemoral ligament from the pubis to the femur. So the names again tell you what two places those ligaments are attached at. So again, this is a ball and socket synovial joint. You can see the synovial fluid here in this picture. This is how it fits into place, okay? All the ligaments there. Common fractures, okay, so the neck of the femur. I think I mentioned it before. When you talk about hip fractures in the elderly, remember 60% of nursing home residents suffer falls. Elderly people fall quite often. And when they fall, hip fracture is quite common. And it should not be called a hip fracture. That is actually a subcapital fracture, a fracture of the neck of the femur, okay? And this is concerning because this can cause like fatal blood loss. Bones are vascular. We mentioned that before. Okay, here's the knee joint. Again, another example of a hinge joint. Flexion and extension is what's possible here. Some of the ligaments, the fibular collateral ligament laterally, and then the tibial collateral ligament medially, the patellar ligament, that is your quadriceps muscles of your thighs, they're all holding it together. And you also have some important structures here. There you go. Something called the ACL, for anterior cruciate ligament, right? Cruciate means like a cross shape, so it's like a cross, right? And it also goes posteriorly to form the posterior cruciate ligament. So ACL injuries are quite common, right? Anterior cruciate ligament injuries. And this is common in people like football players, someone running at top speed and somebody tackles them, and their shin hits someone at top speed, but the knee keeps going. So the knee kind of slides over the shin bone, right? And there's a sudden popping sound, it's quite painful, and the person just falls to the ground because their knee gives way, right? And one thing that you would like to perform on such a person, that you, if you're a sports physician or something, is what is called the drawer sign. And the drawer sign is done exactly like what it sounds like. You're going to gently hold on to the calf of the person while they're sitting with the legs like suspended in the air, right? Legs dangling freely. You're going to hook your fingers behind the calves, behind the knee joint, and gently try to pull the knee towards yourself. You have to be very gentle because it's very painful and they're tender. If the knee like freely glides over the shin bone, like a drawer, it opens, positive drawer sign. This person has damaged their anterior cruciate ligament, either a complete tear or a partial tear, okay? So depending on the severity of the tear, sometimes all you need is bed rest and pain control with like non-steroidal anti-inflammatory drugs and stuff, and just physical therapy. In severe cases, you need to you might need a joint replacement, an arthroplasty, or a ligament repair surgically, okay? So here is your tarsal joint or the ankle, as you can see, right? Again, ligaments, anterior tibiofibular ligament joining the tibiofibular, the tibia and the fibula together. The lateral ligament, see how flimsy it is? So inversion sprains of the foot are quite common because the lateral ligament doesn't do much to protect that end. But on the medial side, you have a much nicer, thicker, bigger deltoid ligament. So eversion injuries are quite rare. The deltoid ligament protects your foot from eversion injuries, as you can see. Okay. Sprains, what are they? Tears in your ligament, either uh, partial or complete tears. How do you treat a sprain? Remember PRICE, the acronym PRICE. So what does that stand for? P for protection, protect the joint. R is for rest, rest the joint, don't indulge in activity again. I is for ice, ice numbs the pain and prevents inflammation and swelling. C is for compression, put on like a broad, big crab bandage, again to prevent uh, swelling there. And E is for elevation, keep the foot with the sprained ankle elevated above your heart's rate, again, to prevent swelling so the fluid can run back to your heart, okay? Pot fracture is when you twist your ankle real bad and you end up fracturing the lower inferior tibiofibular joint. The tibia and the fibula, their distal ends might fracture. It's called a pot fracture. You might do the same in your wrist. So that would be the fracture of your inferior radio-ulnar joint. That one is called Cole's fracture or Colles fracture, C-O-L-L-E, Colles fracture. That is the upper arm equivalent of the pot fracture that you see here. What movements are allowed at the temporomandibular joint? Depression, elevation, protraction, protraction, and retraction, okay? Why is the shoulder joint considered the most mobile? Because it is the most mobile. You can stand, flex, circumduct, laterally flex, all kinds of things. Lateral flexion, medial flexion, they are all possible at the shoulder joint. Why is it most unstable? Because the most mobile joints are usually the most unstable as well. They're easily dislocated. What is the function of the annular ligament? And to hold the head of the radius together with the ulna, okay? What injury may occur this ligament in young children? Subluxation. Subluxation, where the head of the radius might pop out of the annular ligament. How do the glenohumeral and hip joints compare with respect to the mobility and stability? Glenohumeral joint in your shoulder is much more mobile, but less stable, easy to dislocate. The hip joint, which is your femur acetabulo-femoral joint, is much more strong, but not as mobile. Functions of each of the intracapsular ligaments of the knee joint. All right, so protect the joint basically. Anterior cruciate ligament, we talked about that one. What bones articulate at the talocrural joint at your ankle? The tibia and the fibula. What movements are permitted at this joint? Inversion, eversion, plantar flexion, dorsiflexion of the foot. 4 different movements. All right, so this is embryology again. You're basically, your joints form in between 4 to 8 weeks of embryonic development. Different types of joint diseases. Arthritis is an inflammation of the joints, okay, and which is different types that we will be talking about here shortly. Exercise is very important for your joint health. So remember my mantra, a health mantra, DDES LMP. Exercise is important, both aerobic and anaerobic, to strengthen your joints and to prevent problems in the future without overtaxing them. So brisk walking is safer than jogging because jogging will chip away at the cartilage, right? Especially if you're on uneven, rough surfaces, okay? So arthritis is a inflammation of your joints. It comes in different types and forms, like osteoarthritis. It happens with age, more common in men, and men who are like football players, soccer players, body weightlifters, and those kinds of things with a lot of stress on their joints. So what happens with time is their articular cartilage chips away, and so the bones start grinding together. It's very painful. Rheumatoid arthritis is more common in females because this is an autoimmune disorder, okay? And autoimmune disorders in general are more common for various reasons that we have already discussed in females, right? So what happens in rheumatoid arthritis is you have autoimmune antibodies that attack the articular cartilage in your joint and destroys it. So your fingers become like gnarled and disfigured, right? It starts in the small joints of the fingers and then the wrist and so on, right? And gouty arthritis is when gout happens, and gout is when you have high levels of uric acid in your blood because you're eating too much meat and it breaks down into uric acid, and you're dehydrated, you're not drinking enough water at the same time. So these uric acid crystals form, they're sharp crystals, and then they kind of poke your joints, very painful, especially in your big toe, right? So that would be gouty arthritis. So some common signs and symptoms that might help you differentiate the different types. Osteoarthritis. So when you wake up in the morning and you feel like your body hurts all over, but when you start moving around, the pain goes down with your as your day progresses. Most likely, this is rheumatoid arthritis. But if it's the other way around, like when you wake up in the morning, you feel fine, not much pain, but as you start working, then the pain gets progressively worse. That would be osteoarthritis. Okay, why? Because of the different etiologies, different pathologies. Osteoarthritis is about your the stress and the weight on your joints and your articular cartilage being chipped away. So the more weight you put, the more work you do, the worse it will hurt. Rheumatoid arthritis is those antibodies and fluids that accumulate in your joints. That happens overnight when you're sleeping. So they're red and hot and swollen and inflamed when you wake up. As you move around and blood starts to circulate, the blood will flush away the antibodies from your joints. You feel better. So that explains why that is the case. Some ways that joints change as a person ages: the cartilage becomes thinner, the bones become weaker, the ligaments become weaker, you're more likely to fracture your bones, you're more likely to get sprains and strains, and also develop arthritis, both osteoarthritis and rheumatoid arthritis, and even gouty arthritis. All right, so there we are. We are done with chapter 9 as well. Uh, I will be sharing these recordings with you and the notes for both yesterday and today. You have the study guide for your lecture exam on Wednesday, so use it. Lab exam would be on Monday. Have a fantastic long weekend, and I will be communicating with you. So keep checking your email in the meantime, and then I will be sending out more lecture recordings starting Monday. So have a great weekend. Bye-bye.